Hello, HHT community, and welcome to our latest webinar. Today, you will have the opportunity to hear a comprehensive review of management options for HHT-related nosebleeding. Whether you're newly diagnosed or not, we're glad you're here, as treatment options available for HHT patients are rapidly evolving. We want to ensure you're aware of all the options available to you. As for me, my name is Riley Blevins, and I'm the Senior Director of Community Engagement here at Cure HHT, and I'll be moderating tonight's session. But before we jump in, I first want to make you aware of some important news and announcements here at the Foundation. We have many new programs launching here at Cure HHT, the first of which is HHT Connect, the first ever global HHT patient registry. Our goal here is simple: to collect health information from as many HHT patients as possible so that researchers and doctors can discover patterns and clues that can help them better understand HHT and develop new treatments. By answering a handful of simple questions, you can help advance HHT research and do so all from the comfort of your own home. I would strongly encourage everyone here to visit our website, learn more, and sign up. It's a small way every patient can help advance HHT care. The next program has been highly requested. Cure HHT is excited to announce the launch of the HHT Continuing Education Hub. Now, providers seeking to further their HHT knowledge can receive continuing education credits at any time when they complete a course online. While these classes are geared more toward medical professionals, patients, you can play a role in advancing HHT awareness by sharing information about this program with your local non-HHT doctors today. Visit our website to learn more. Our webinar today is brought to you by Bleed Cease. Stop bleeding fast and easy. We deeply appreciate Bleed Cease partnership and support in making programs like this possible. As part of their sponsorship of tonight's session, Bleed Cease is offering a special offer for HHT patients. You can click a link in the chat to receive a free sample of Bleed Cease. Next, we have just recently expanded the criteria for our newest clinical trial, the pazopanib study. Check out our website for more information and to see a recording of a past webinar that will answer all of your questions about pazopanib. If this trial is successful, this drug could be the first FDA-approved medication for HHT, which would be a huge milestone, but we need more participants. Please head over to our site and learn more to learn if this study is right for you. We also have several other research projects underway that you can learn more about on our website, things like the Brain Vascular Malformation Consortium and tissue donation. Again, head over to curehht.org to learn more. Next, when it comes to HHT and why you're here tonight, it's because knowledge is power. And one way to gain comprehensive knowledge is by checking out the Living with HHT book by psychologist Sarah Palmer. She's an HHT patient herself, but also an expert in helping people cope with health conditions. This book, it's currently available in 2 different languages, both Arabic and English. Finally, before we get underway, I want to go over some rules and housekeeping notes tonight to make this webinar and event as interactive as possible. If you have a question tonight for our presenter, please type it into the Q&A box to the right of your screen. We recommend that you keep your questions general in nature so they benefit everyone. I will ask as many questions as time allows. We will also be posting resources relevant to tonight's topics in the chat box. You can use the chat field to make comments to either one individual or all participants on this webinar, but please do not post your questions for presenters in the chat box. Again, questions for our presenter tonight should be typed into that Q&A box. This presentation is being recorded, and that recording will be saved to the Cure HHT website's resource library. And at the end of the discussion, you will be emailed a survey. Please do take a few minutes to fill that out, as your input is critical in the development of future webinars just like this one. And with that, let's get going. It is my pleasure to introduce tonight's speaker, Dr. Jeb Justice. Dr. Justice is an associate professor and the associate residency program coordinator at the University of Florida's Department of Otolaryngology. He's been with US since 2012 and is the co-director of the University of Florida's HHT Center of Excellence and is incredibly dedicated to providing expert care to many HHT patients. Again, please do take advantage, because at the end of this session, we will hold a 20-minute moderated Q&A session with Dr. Justice. Dr. Justice, I'll let you get your slides up and turn things over to you, but while you're getting set up, we do have a poll for the HHT community. Since nosebleeds are the most common symptom, we want to hear from you. What resources can we create here at Cure HHT that will be most helpful to you in helping you manage your bleeds? please fill out that poll, which will be posted shortly. We really do value your input. With that, Dr. Justice, it's all yours.
All right. Thank you, Riley and Courtney. Thanks everybody for being here. Let me try to share my screen. I'm very technologically not savvy, so bear with me. And I have a lot of slides, so I want to try to get through them. Hopefully have some good information. I think the background slides we can probably get through pretty quick because I really want to get to the meat of the talk, which is the medical and surgical treatment options and their pros and cons. All right, so here's an overview of what we're going to talk about, the diagnostic criteria and the guidelines update. If you're not familiar, they're the second HHT guidelines were published in 2020, and we'll briefly touch on those, and then we'll go through treatment options. I always like to give a shout out to my 3 mentors with regards to sinus and HHT care, and then the people I met along the way in the last 2 years since we've become a center. These people have really taught me a lot about HHT and how to care for HHT in a multidisciplinary fashion. I do have 2 disclosures to report: Medtronic and 3D Matrix. I'm a consultant for these 2 companies. So background, a lot of you know this, and you can get this information from the HHT website. This is a genetic autosomal dominant disorder that we think is in about 1 in 5,000 at least. We think there's a lot of people who are not diagnosed. About half of patients will have nosebleeds before 20, and almost everyone will have them in their lifetime. When we teach our residents and students, we try to divide it up into what are the nasal symptoms, what are the effects of their anemia, and then what are the extranasal symptoms or the symptoms throughout the rest of the body. I'm kind of a history, at least a wannabe history nerd. I like looking back at when diseases, especially rare ones, were discovered. And so these are some of the earlier articles about this. You know, HHT, we originally called it Osler-Weber-Rondeau. And this is a publication by Dr. Osler where he mentions a case report by Dr. Rondeau from 1901. This is also another one from Johns Hopkins from 1909, just showing some of the early descriptions where this HHT was originally described. So as an overview, I may be preaching to the choir here, but there's limited treatment options. Thankfully, that we are getting more and more as each year goes by. One of the challenges for patients is that not all otolaryngologists, or we'll say ENT docs for short, have experience with HHT. My dad's a retired HHT, and he may see 1 per year where I see, 10 per week. And not all ENTs want to see it because it is a difficult disease to treat. And, as surgeons, a lot of us go into surgical fields because, we do a surgery and we think we're going to cure someone. Well, there's no surgical cure for HHT without a massive trade-off. And I'll talk a little bit about the Young's procedure at the very end. But I will say, compared to when I trained at the University of Utah, which was, I think, the 2nd or 3rd center in the nation. And, when I was training, it was basically pack your nose, put some ointment in, do laser or do surgery. We didn't have a lot of other options. So there's hope, and I'll try to get that to you all tonight. We do know the pathophysiology, the inner lining of the blood vessels. There's endothelium or endothelial dysfunction. This has been pretty well worked out. I think most people here probably know their mutation. The most common is the ENG and the ALK1 or ACVRL1 for type 1 and type 2. There's a SMAD4 and a couple other less common ones. But it does seem that, there's a higher frequency of pulmonary AVMs in type 1 ENG, whereas there seems to be a higher likelihood of having liver AVMs in type 2. The diagnostic criteria is well defined. There's 4. The first one's epistaxis. The second is to have the telangiectasias in one's nose. The third is the visceral lesions. That would be the GI, brain, pulmonary, liver. And then the family history. So 1 first-degree relative. If you have 4 out of 4, it's a definite diagnosis. If you have 3 out of 4, it's a probable diagnosis. Or if you have a positive genetic test, it's a definite diagnosis. So one of the things I share to the students, just one way to think about this: if you have 100 HHT patients in your office, 90 to 95 will have nosebleeds, 30 will have pulmonary AVMs, 20 will develop GI bleeding after age 50, 10 will have CAVMs, which stands for cerebral or brain AVMs. 5 patients will have symptomatic liver disease. And overall, if you put pulmonary and cerebral combined, it's about 40%. So here's some pictures from some of our patients. This may be well known to y'all. These are some of the extranasal lesions here on the hands and the tongue. These are some pictures here of lesions in the nose. And this is what's so unique and fascinating and difficult about HHT is that no patients are the same. You see some who have one or two small lesions, one or two large lesions. You have people who literally have hundreds of lesions like this, and they can be from small to medium to large. This is actually a picture looking down someone's throat where the breathing tube is in, and they actually have abnormal vessels here at the vocal cords in the top of their voice box here. It's another chart here showing that, we think of E. epistaxis as the cardinal symptom or most common symptom of HHT, and 90 to 95% of patients will have that. The bleeding does seem to get worse with age. It can happen in childhood, but most of the time it's my adult patients who are having more trouble, and it seems to get worse with age. We do know that the airflow, literally the airflow that you're breathing in, is the trauma that causes the problem, right? The nose and sinuses are a sacrificial filter for the lungs, right? And so it takes on everything in the outside world, but the airflow through the nose can cause the vessels to form and the vessels to crack and bleed. And part of the way we know that is from the Young's procedure, or what I'm going to show you later is when you cover things up with a splint, the bleeding reduces and the vessels seem to shrink away. And then I think I'm going to talk to you about a classification system in just a minute. We touch on this a little bit. Telangiectasias can be very, very different. They vary in morphology from small, flattened, and stellate lesions to even large connected or conglomerated lesions. Crusting and dryness of the lining of the nose that we call the nasal mucosa, or a hole in the nose from common procedures can be sites of the bleeding. And then iron deficiency in conjunction with low ferritin, elevated transferrin is characteristic in these patients. So tend to have iron deficiency anemia, and it's tough. A lot of my patients are on iron supplements, and it can be tough to get their ferritin levels up. This is one of the papers from residency. So I read this about 20 years ago that really helped me understand how much HHT can reduce someone's quality of life. And my mentor posed the question of, which part about the nosebleeds do you think it is? And it was kind of like, well, I guess it's if they bleed a lot. And it's not actually, this study showed it wasn't actually the frequency that was the main driver, it was the duration. And the authors suggested that HHT patients were so sort of used to bleeding and adept at controlling their bleeding that the frequency didn't matter as much as the duration, because when a bleed goes long, it represents kind of a lack of ability to control it. And that's what really drove down patients' quality of life. So that really hit home for me. Here's a couple more pictures and to show the classification. You can have the type 1 here, which are the small punctate, like isolated lesions. You can see there at the top right of the screen. And then type 2 would be the smaller but kind of interconnected lesions. If you look at the 3 at the bottom, it's the one in the middle. And then the ones that are more like an AVM, a larger telangiectasia, like an arteriovenous malformation, would be there on the bottom right, where those are the ones I really, really like for sclero, because you can really get your needle right there in the middle of that vessel. We'll talk more about that later. But I'll put it here at the bottom. Morphologic characterization can be useful in treatment planning. For example, lasers for the small one is a reasonable option versus if they're interconnected or larger, I might think to myself, sclerocoblation or cautery. And not all cautery is the same. I'll talk to you a little bit about that at the end. The old school way to do cautery is not my favorite thing here, and that can cause a lot of tissue damage, but I'll show you some options later. And here's just a close-up of the type 1 on the left, type 2 in the middle, and the larger AVMs for type 3 on the right. Hopefully everyone here has seen the epistaxis severity score. This is a validated quality of life, measurement, and we use this, right? This doesn't diagnose HHT. This helps us assess the severity and the response to treatment. And so there's 6 questions. They each have a weighted, a weight that how much they go into the score. And we ask this on every patient's visit. You can actually I actually go to the Cure HHT website, do this questionnaire with my patients, and then screenshot and put that in. And that's how we keep track of are the treatments working or not. But if you think about the questions, the first one is just about frequency. So how often. Number 2 is about duration, how long. And number 3 is about severity or intensity. So that's the gushing or not gushing. And then the other ones are, have you had to seek medical attention to stop a nosebleed? Are you anemic? And have you received a blood cell transfusion, a red blood cell transfusion? And that's, the main way that I monitor my patients. Obviously, we use labs like whether they're anemic or low ferritin as well. So let's get into kind of the meat of the talk here. I'm going to go through the guidelines, then we'll go through medical treatments and surgical treatments. And so this was published back in 2020 with looking at randomized controlled trials for treatments in HHT with people 18 years or older. Okay, so they divided them up into the guidelines for each part, and I'm only going to focus on the nosebleed or epistaxis one. So for number 1, patients with HHT-related nosebleeds should use moisturizing topical therapies that humidify the nasal mucosa to reduce epistaxis. And that goes back to that idea of the airflow, right? You're kind of trying to put a little liquid Band-Aid on there to minimize the airflow directly hitting the surface of the nasal lining or directly hitting the vessels. It doesn't work in everyone, but it's so safe and easy to do that it was a strong recommendation from the panel. All right, moving on to A2, clinicians should consider the use of oral tranexamic acid for the management of epistaxis that does not respond to moisturizing topical therapies. So we say TXA for short. A lot of patients will come in and say, I'm on the acid pill. And you have to make sure that that's not, like Pepcid or Prevacid or something for, GI acid reflux. But tranexamic is kind of a hard word to say. But again, a strong recommendation from the panel. And I'm going to talk a little bit more about this because there's some pros and cons to this. But it is, for moving from topical up to what I call systemic therapy, the guidelines recommend oral TXA as the first one. And then A3, clinicians should consider ablative therapies for nasal telangiectasias, including laser treatments, radiofrequency. That's referring to coblation. I saw some questions about coblation, electrosurgery, and sclerotherapy in patients that have failed response to moisturizing topical therapy. So that might be something where, let's say that they didn't respond to the topicals and the TXA, or that they had a side effect with TXA. I might consider moving up. So that's the other thing you have to talk about with your doctor too, is like, well, some will say, oh, we're going to take you to surgery. But if sometimes I actually take someone to surgery to do a laser or sclero, I'm not actually cutting or doing surgery per se, but it is a procedure. And some of the procedures have to be done in the OR, and some of them can be done in the clinic if the patient's a good candidate. All right, so moving up, A4, clinicians consider the use of systemic anti-angiogenic agents for the management of epistaxis that has failed to respond to moisturizing topical therapies, ablative therapies, and or tranexamic acid. And we'll get into the names of those. So those are anti-angiogenic agents, basically meaning medicines that are trying to stop the growth of blood vessels or reduce existing blood vessels. A5, clinicians consider septodermoplasty for patients whose epistaxis has failed the above mentioned things. We're going to talk about septodermoplasty. I have not done that since residency, and I'll tell you why towards the end of the talk. Finally, A6, clinicians consider nasal closure. So that's what we refer to as the Young's procedure for patients whose epistaxis has failed to respond sufficiently to moisturizing topicals, ablative therapies, and or TXA. And you can see there were the strength of the A5 was weak, and then the strength of A6 was strong. And so I think I'll speak to that as I talk about the pros and cons of the procedure. A lot of these medications I was not prescribing in residency, and actually I will prescribe oral TXA now. I have my partner here prescribe the bevacizumab, what's called Avastin, just because that's a medication that's out of my scope. But we'll touch on it in a minute. But I keep these doses handy just in case. And then finally, for the guidelines of nosebleed management, A10, the expert panel recommends that treatment for acute epistaxis requiring intervention So this is, nosebleed you can't get stopped. It should include packing with material or products that have a low likelihood of causing rebleeding with removal. So what that means is, right, there's packs that need to be taken out, or there's packs that basically dissolve on their own. And I try to teach our residents that if you can get it stopped with absorbable, that's good, because that means the patient doesn't have to have it pulled back out, because you can obviously pull it out, disturb a scab, disturb a different vessel, and cause more bleeding on the removal of it. If the bleeding is severe and one does have to place a removable pack, it should be lubricated with ointment, or already some of the packs are pre-lubricated. So let's move on. And these are other good ways to think about this. This is kind of like what we have in our clinic when we're going through options for the patient. So this is a paper by Dr. Al-Samkari, who I mentioned on one of the earlier slides. So I'm not going to go over the GI stuff on the right, but down the middle for epistaxis, right? Initial management or mild bleeding is the moisturizing topicals. Up to moderate, if that's not working, oral TXA or the local ablative therapies, which would be like the coblation, radiofrequency, the very mild forms of cautery or sclero. And then the next option down are either the big surgeries like nasal closure and septodermoplasty, or Avastin or bevacizumab, I guess I should be saying, for the systemic angiogenic agents. So nice review. So when you see something that has multiple treatments, that usually means that we haven't found the one that works the best yet. So this is a lot of the different ones. I'm not going to go through all these because I don't use all of these, but some patients respond to various things on here. When I'm talking about the non-surgical management right here, the medical management, I try to divide it up in my mind to the systemic and to the topical. All right, so we'll go through these here, and hopefully you've heard of most of these. Rose geranium oil, sorry, I forgot that one. So this is another good review article by Dr. Al-Samkari. So topical formulations. So people have done studies with putting the various medications in the nose topically, such as estrogen or estriol, tranexamic acid, and topical bevacizumab, as well as injecting bevacizumab, have all not really shown great long-term results. You'll hear from patients that, sometimes they did have a good result, but when you look at everybody grouped together kind of long-term, the results have been kind of disappointing. And estrogen could theoretically work, but we try to only do it topically. And you can imagine trying to give estrogen to a male patient. They're usually not interested in that. And giving systemic estrogen has, risk of blood clots. And so that's why they looked at those all as topical. All right. So let's talk about other topical things. A lot of people will say to use saline to moisturize. I would say that's mixed for me. Some patients, I think, tell me that does help, and then some patients tell me it kind of knocks the clots off and bleeds. So I actually like either the Vaseline, the Mupirocin, AYR, Aquaphor better than I like saline. And then thermosensitive gel's been studied, but that's kind of hard to get. And then rose geranium oil, which is actually readily available. So I just wanted to touch on this really quick, because we used to do a lot of these bevacizumab injections in the operating room at the end of a surgery. And we did it. This is two things about this slide. We did it because they seem to have a significant improvement. This was a study from Dr. Davidson in San Diego in 2010. And what they actually noticed is when they picked out their injection sites, and a lot of people have telangiectasias on the septum, but what they started to notice, 5 out of 52, that's almost like 10%, were developing a hole in the septum, or a septal perforation. And so as they continued, they stopped injecting in the septum and only did like the nasal floor and the sidewall and the turbinates, and they didn't have any more septal perf. So we have to be real careful with this. I would tell you in my practice, some patients tell me this does work for them, and some tell me that it does not. So for me, when discussing intranasal injection of bevacizumab or Avastin, I tell the patient exactly what I told you, and let them decide. It's kind of a patient decision, patient preference. Topical beta blockers. So people probably heard of these, right? These are originally blood pressure medications, but they can also have some properties that stop blood vessels. So what we kind of discovered this actually, we actually took care of this in ENT. I saw this a lot in residency, where babies would be born with what's called a hemangioma, which can be an abnormal formation of blood vessels anywhere, but some of them developed them in their airway and it was blocking their airway. And someone decided to do a beta blocker called propranolol, and it has a dramatic effect on shrinking these hemangiomas in babies because the only other option was a really, really risky surgery. So then we got the idea, well, maybe we can try this in HHT patients. And you can see here the study on the top right was only 6 patients and it was retrospective and there was like no placebo control. And so it's not really, a great study. And then the bottom or the kind of middle right looked at similar beta blocker nasal spray. So this is how I get it for my patients. If patients have had success with this, you get it as timolol. It usually comes as an eye drop, and we just have patients put it in their nose. The brand is Betamol or Timolol, but this particular study did not find an improvement. Okay, so remember I briefly had thermosensitive gel on a previous slide. And this study was by Dr. Picarillo in St. Louis, where they put the beta blocker in this thermosensitive gel that you would place into the nose. And the interesting thing was that both groups improved. And so that kind of speaks to the fact that it might actually have been the gel helping it. But the problem with doing that long term is that, that gel's more expensive and hard to get than Vaseline, and you had to put it in 2 times a day. So that kind of started our minds rolling of like, okay, well, maybe we can have some sort of liquid Band-Aid. We just need something that lasts a little bit longer. All right, same concept, rose geranium oil is not something I had heard of until residency and started talking to HHT patients. It's actually been studied in a small study here. And it was well tolerated. The nosebleeds improved, but again, it was not placebo controlled. So there was no control group. And I put in the link there. This is at the bottom is the link to the information on rose geranium oil that's at the Cure HHT website. And the way it works is it's an astringent, which can cause contraction of blood vessels, but it also speeds up coagulation. So it may have multiple benefits. So that's one of those things patients are welcome to try. I'll say, maybe that you can usually get this online or at a health food store. And if cost is not a problem for a patient, then rose geranium oil is very reasonable to try. So now we're going to get more into the anti-angiogenic and anti-fibrinolytic stuff. So it's kind of an alphabet soup here with a lot of big words. When you think about TXA, we'll talk about the mechanism. If you look down here, kind of middle left, tranexamic acid is actually what's called an anti-fibrinolytic. So it blocks the lysis or the breaking up of the fibrin clots. Okay, so that's basically how you should think about it. The body comes in, anytime you make a clot, your body sends in other cells later to break up that clot. And this kind of prevents that from happening, or at least slows it down. And then anti-angiogenic, we've talked about bevacizumab, and then Riley mentioned pazopanib earlier. And then I'll briefly touch on doxycycline as well. All right, so get back to TXA. The long name is tranexamic acid. The brand name's Lysteta. Sometimes you'll see that. Amicar aminocropoic acid is another thing that is similar. But these are generic. They're in general not super costly, readily available, and they stop the body's own clot busting ability. While these agents have a theoretical risk of a blood clot, studies in HHT patients have not found any increased thromboembolic risk with their use. However, we have to be careful. So the mechanism, right, it shouldn't be able to cause a clot. It only stops the breakdown of an existing clot. The problem is you have to be real careful and ask patients, have you ever had blood clots in your leg, or are you at risk for a clot, like in somebody like atrial fibrillation or AFib, because they may already actually have small clots. And so if I find somebody with AFib or who's on a blood thinner for some other clotting problem, then I will not offer them TXA. All right, so then moving from antifibrinolysis to anti-angiogenesis. So again, angiogenesis meaning the formation or growth of blood vessels. Bevacizumab or Avastin are probably most common right now. It's typically given as an IV infusion, and it blocks VEGF-A. So that means vascular endothelial growth factor. So it's a molecule that basically promotes the formation and maintenance of blood vessels. The next is pazopanib, which is a small molecule VEGF receptor tyrosine kinase inhibitor, and that's what's in the study right now. So in general, I'll go to the last bullet here. Although studies directly comparing anti-angiogenics with surgical treatments don't exist, the accumulated evidence strongly argues that systemic targeted anti-angiogenic therapy is the most effective treatment modality for achieving durable global hemostasis and normalization of hemostatic parameters in those patients with moderate to severe HHT-associated bleeding. And I would say I agree with that. If I have someone who I've done multiple procedures on and still can't get them under control, I ask my partner to try to get them on bevacizumab. And so here's some of the studies to back up that claim. So 146 patients treated for more than 3 months. And clinically, everybody should know too that ESS score, I forgot to mention this earlier, that's a 0 to 10. What has been defined as a clinically meaningful reduction in reduction of nosebleeds is 0.71. And so in this study, 132 out of 146, which is 92%, had an improvement. And the side effects were in general not too bad. So you can get spike in blood pressure, fatigue. Proteinuria means you're leaking a little protein into your urine, which is affecting your kidneys. And then venous thromboembolism is a blood clot, so in 2%. So those are things we have to monitor for. But I do have several of our most challenging patients on this medication. So here's the PATH study that was pomalidomide that just closed a couple years ago and was published last year. Pomalidomide was looked at 13 HHT treatment centers in the US and had 144 patients. It was about 2 to 1 for treatment, pomalidomide versus placebo. And there was an improvement. So there was a clinically meaningful reduction in epistaxis severity score at 12 weeks and maintained at 24 weeks. But in my mind, it had a little bit more side effects than bevacizumab. So 25% dropped out, 14% of the was due to AE, which is adverse events. And you really have to monitor people's blood count. So 45% had neutropenia, which means a drop in your white blood cell count. 60% had GI side effects. So it helps the nosebleeds, but you have to monitor patients closely for side effects. All right, here's doxycycline. So this is controversial because if you look at the studies, most of which have been small, they show no statistically significant reduction in the nosebleed frequency, duration, or scores. And when they asked about gushers, there was a suggestion that it might help a little bit with that. So the reason I'm bringing that up is what I see clinically and what I hear from my colleagues clinically is with doxycycline, it either helps or it doesn't. Like when we talk to patients about it, they'll say, Doxy changed my life, or this didn't work at all. It doesn't, I rarely do hear someone say it, oh, it helped me a little bit or helped me medium. And so I will actually, before I'll start someone on TXA, I will start patients on Doxy to see if they're a responder or not. And we're actually looking at right now, trying to see if the genetics predict the response, because they didn't report the genetics in the Doxy studies that I've read. Because I want to know if someone's a responder or non-responder. If I give this to somebody for 6 to 12 weeks and they don't respond, then we know we don't have to worry about it or talk about it again. But some patients respond dramatically. And so we know we have another tool in our toolbox if we get into a pinch later. Doxy's unique in that it's an antibiotic, but it has some properties that block some of the molecules that form blood vessels. The things you have to monitor for too is it can make you really sun sensitive. So patients can get sunburns, and down here in Florida, that's a big deal. And the absorption of doxycycline is blocked by calcium. So in general, I try to get people to take this on an empty stomach or at least 2 hours away from a meal, especially if that's got cheese, ice cream, yogurt, stuff like that. And we really shouldn't be giving it to children as well, because it can make their teeth turn yellow. All right, moving on. So I'm going to move out of the medical treatments and into surgical treatments here. Make sure, gosh, I'm running late on time. Okay. So laser, sclerocoblation, splints, electric artery gels, and septodermoplasty in the Young's procedure and embolization. So we talked about this in the guidelines. I won't go through that again. But clinicians and patients should choose the specific ablative therapy based on local expertise, understanding that these therapies are usually a temporizing treatment, right? We already said there's no surgical cure. And in general, procedures have the ability to cause tissue damage, including septal perforation. And that becomes very difficult to treat because it causes more turbulent airflow, which can lead to worsening bleeding. So I saw a couple of questions about that. So yeah, a lot of my patients with perforations will actually bleed from the edge of the perforation where a lot of the turbulent airflow happens. And so with cauterization, you really have to ask your surgeon what kind it is. We would like to avoid monopolar cautery in general, especially if we're on the septum, okay? So laser to me is controversial. I'll try to go through these as fast and give you my thoughts. Laser, I think, works the best on the small lesions that are not connected. It's really nice because it doesn't damage the tissue and you can combine it with other treatments. There are some safety things you have to do in the room to protect all of your team in the room and the patient's eyes. But in general, if you pick the right patient, laser can be fine. This is an example on the left of a nice small lesion that was lasered, and you have to do this kind of multiple times coming from the outward in, but you can see it has a nice result there. The lesion is gone with very, very minimal tissue damage, okay? There's multiple different types of lasers. I would say most people use the KTP. That's what I trained on. But again, I'm using this in select patients with smaller lesions and have really favored sclero if it's a medium or large lesion. And then at the bottom too, so it can't penetrate through water, and so laser photocoagulation is relatively ineffective in situations with active bleeding. That's one of the reasons I don't like it, because if you hit the vessel in the wrong spot and it starts bleeding, then you're kind of in trouble and you got to pack and slow it down. So like I said, patient selection here is huge. Again, this was comparing different lasers. I only have access to the KTP. I have not used the ND YAG or the argon. People have tried this in clinic. I think this is possible, but you'd have to be real careful and really select your patients very, very carefully. So sclero. So this is, again, thanks to Dr. Picarillo and Dr. Boyd for teaching me this. Dr. Boyd, they published on this a bunch. And this basically, you mix a medication with air, you make a foam, and you inject it directly into the vessel, and it causes the blood vessel endothelium, remember that lining of the blood vessel, to kind of like slough off, and the vessel collapses on itself. And it's really nice because it doesn't cause a lot of collateral damage, and you can do it in the office or in the operating room. The disadvantage of doing the office is that it's really, really hard to get to the back. Or if the patient starts bleeding really bad, then it's kind of hard. So the studies on this have been, universally good. This is from Dr. Boyer's group that reported an increase in, a decrease in the bleeding, and really no complications other than some congestion, sneezing, and vasovagal, where the patient dropped their blood pressure. There has been a described case of blindness, but this was like 10 to 12, 14 years ago, where we used to mix the sotradecol, it's called sodium tetradecol or sotradecol, or STS for short, with saline. And that case of blindness had us kind of scared. But once we figured out to start mixing with air, there's been no reported cases of blindness. And I've been doing this for about a year and have done about 50 patients and have not had any severe complications like blindness or any bad outcomes. This is a study from the Cleveland Clinic. that actually compared sclerotherapy with laser. In this study, there was not a huge difference in the hemoglobin levels, iron stores, quality of life scores. But one of the things that was interesting is that patients, to keep them under control, needed less procedures if they were in the sclerotherapy group. So only 1.6 versus 3.6 in the laser. And then the other difference was it favored sclerotherapy for less of the post-operative, you get crusting and clots and septal perforation and stuff like that. It seems to be much more gentle on the surrounding tissue. Here's an example. This is not in the nose, but in the tongue, because you can do sclero anywhere. This lady had a very large AVM basically on her tongue that bled pretty much every time she ate. Here's us doing, this is asleep in the operating room, as you can see. This is us doing the sclero, myself and my resident. And we get a little bit of bleeding for about a minute, but those ones that are big and juicy like that are really our favorite ones because you have a higher margin for error. And so we did sclero on her, and I'll show you her outcome. Here was her on the left is before. That's why we were doing it twice there, is because there was 2 lesions. And then 2 months later is what it looked like on the right. And I just saw her this past week. It's been about 9 months, and she still looks great on her tongue. So that's when I became kind of a believer in sclero. But again, you got to choose the patient and the lesion properly. Here's a case of us doing it in the office. You got to get the needle just right. And this patient is awake with just numbing medicine in the nose. And there you can see the sclero going in and see how it kind of makes the red vessels turn white. And then you see some more of the foam come out. So that's what it looks like. Here's another example. This is on the patient left going inside with a very large lesion there. See that? It's big enough to almost call an AVM. And it's got some crusting over it, you'll see. But once we release the foam, you're going to see the whole thing kind of turn white right there. And that's it filling up the vessels. So that's kind of the thing we want to see with that. So quickly moving on to coblation. Coblation and the irrigating bipolar, which I'm going to talk about in a minute, are kind of similar. And these, I think, are acceptable forms of cautery. They both are low energy, and they both irrigate saline at the same time. And so you have less of a char and a scab. So if I'm doing something where I don't think sclero is good, and I'll show you a couple examples, these what I would use, either the coblator or the, here's an example of it right here. You see that small lesion, see the saline coming out, and then you see it blanch the vessel there, and see it just turns that nice soft white instead of a dark char that you get with your other. And then here's an irrigating bipolar, which does similar. There's that isolated lesion there. You get the lesion between the 2 tines. It runs some saline with a little electric current and just knocks it out just like that. So that's the kind of thing. Remember, I'm doing that on the turbinate on the sidewall. It'd be much less likely to be super aggressive there on the septum, which is the left of the screen. So I might try to sclero those on the septum while doing the cautery on the sidewall. So septal dermoplasty is the one that you basically, we talked about this in the guidelines. This is where you actually take off the lining of the septum, and then you take a skin graft from a different part of the body and replace it. Okay. The problem, as you would expect, is it causes a lot of crusting, which causes a lot of foul odor. And you really have to almost saline irrigate your nose and saline spray your nose, because now you don't have the normal lining that sweeps the mucus away. And it'll actually stop the bleeding, but you're trading the lack of bleeding for another problem. So at the top left is the skin graft getting ready to go in. On the top right is the cartilage. That's actually after the pink mucosa has been removed, or the pink lining's been moved. And then the bottom right is where the skin graft is placed along there. And again, like I said, it works, but it's kind of trading one problem for another. This is another study. It got me thinking, because we do a lot of patients with septal perforations. We leave splints or buttons in there to help them. And I read this article where they talked about using septal splints, and I thought, well, why can't we try that? So here, this is just an option. This is, instead of doing a septodermoplasty or a Young's procedure, this is what I would offer the patient. So you can keep that tube on. This is a septal splint or made out of silastic, or you can take that tube off, so you just have a flat piece of plastic. So and you'll see what that looks like in just a second. So that's me cutting it in preparation. And so this patient did not want the little breathing tube. They just wanted the flat area. And then once that goes in the nose, that's what it looks like. You can see they still have an area to breathe. This is looking in the left side. And this is the type of patient I would do that in. This person you would not want to go in and cauterize. There's too many. And this was actually before I was doing sclero. I might like to try sclero on a couple of these, but it was so bad on both sides that it's too much of the foam to go in. They're only supposed to give about 3 milliliters to a patient. And so I wouldn't be able to do all of these with sclero. So I offered her splints. And this is what she looked like. Let's see if I can get the video. You can go in there. That's the flat part of the splint. We cut the tubing off. You can see this is post-operatively. There's a little bit of scabs and crusting from what we did on the sidewall, but she's still got a nasal airway, and there's not a lot of crusts and clots on the septum. There's the blue stitch that holds it in. And so not everybody likes this because it's like, oh my gosh, I have this splint in my nose long term. But in some patients who are really, really bad, it's a good option. And so this is what it looked like after I took it out. So the before pictures on the top and the after, I don't know why my video is not working over there, but see how that septum now is healed and the vessels are gone. So that's what happens if you totally shut down the airflow. Now she kept hers in for about 4 months. We took it out and then it looked like this. And then within about a month, she started bleeding again. So she's had a second set of splints in for 9 months. And then finally, that idea of liquid Band-Aid, we're kind of looking at gels that last longer, but this is something that would look like is putting in a gel that sticks to the sidewalls and covers up, for weeks on end if we can. Finally, I'll close with the Young's procedure, which is closing the nose. Again, this works, but you're trading one problem for another. It's been described, it's been done for decades. I've probably done about 6 of these in my career. Dr. Lund over in the United Kingdom probably has the biggest cohort of anybody. And again, it works. Look at complete cessation of nasal bleeding in 94%, but you become an obligate mouth breather. Most people lose their smell and taste. And you can develop little holes where airflow can go through. So here's the idea. We make 3 flaps right inside the nostril and suture them together. And here's just some examples of a patient. That patient had perforation. They're still bleeding. There's the end result of the Young's procedure right there. These are people who developed little tiny holes. Sadly, after it was a couple months after it was done. Here's one of my patients here at UF. So that's what it looks like. You can't really tell if you're walking down the street and see somebody, you can't tell that, but you look up like that and you see. But a lot of times if somebody wants this, I would offer just do one at a time. I'll tell people to pick their worst side and just do that one first. And that's what he did. He picked one side. He did great on that side for 5 years, but since he was getting so much more airflow for the other side, he started to bleed. And now, then he came back and wanted the other side done. And he's doing great. He hasn't bled in on whichever side had the Young's procedure since it was done. Now that we have different therapies, he might be somebody I might talk to about reversing that and seeing. Drawbacks, like we said, loss of nasal breathing, loss of sense of smell, potential obstructive sleep apnea. And if they do bleed, you have no way to pack it. So there's been case reports of people having to have a breathing tube put down and have a throat pack put in the back of the throat to stop bleeding in that situation. This is that case right here. Multiple transfusions, failed the throat pack, and then they had to go in for embolization. Still didn't work, so they had to reverse the Young's procedure. Embolization, I'll talk about. I think the takeaway for tonight on embolization is that I would probably only look at this in an acute situation where you just can't get the bleeding stopped, because all the studies have shown that it will help for short term, but that the bleeding eventually comes back. And so I don't do this very often. This is where you can like go through someone's arm or their leg and go up through the vessels into the back of the nose. And they don't do the ones that go to the brain. I saw there's a question about that. There's a difference between the branches of the carotid. And so we usually only do the branches of the external carotid that go to the nose, not the internal. So that saves the brain and the eye. But like I said, this is a short-term thing that usually the bleeding comes back a year or 2 later. And that's what these studies here are showing. Okay, so in summary, because I want to get to questions, almost all HHT patients suffer epistaxis. Medical management works well in most people. procedural things or surgical ablative things for failures in repeat sclero or the irrigating bipolar or splints or my intermediates. If somebody's failing the sclero and the irrigating, I would offer them splints before I would do Young's procedure or septodermoplasty. That's just my opinion. Not everybody agrees with me on that. And with that, I'll try to open the chat and take questions.
Thank you so much, Dr. Justice. Wow, that was a lot and very thorough. We really appreciate your time and expertise here today. If it's okay with you, I might ask, do you have a few extra minutes to tackle some of these questions here? The chat is certainly popping up live.
For sure, for sure.
Thank you very much. But certainly you can understand how treatment options are evolving rapidly in terms of what's available for HHT patients. It's one of the factors why at Cure HHT we're looking to sponsor an update to our guidelines in 2025 so we can include some of the updates in terms of science research and treatment options that weren't available the last time we updated our clinical guidelines as well. You heard a lot about sclerotherapy tonight, and I'm sure some of you are very familiar, maybe even have had the procedure done, and some maybe just hearing about it for the first time. At Cure HHT, we have issued a grant for ENTs. I believe, Dr. Justice, you might have spent some time with Dr. Piccirillo for ENTs at our different Center of Excellence around the country to go to Washington University in St. Louis and learn from Dr. Jeb Piccirillo, who is an early adopter of sclerotherapy. So hopefully that treatment option becomes more widely available to more patients across the country. And we will actually be having a webinar with Dr. Piccirillo specifically about sclerotherapy here in the coming months. So please do stay tuned for that. Okay, where to start with questions? Because we certainly have plenty of them. I'm going to try to group a few questions we have about COBLATION together for you, Dr. Justice. A lot of patients asking how much is too much, when should they weigh that treatment option for them. I know you spoke about it or touched about it in your presentation, but not sure if you wanted to add anything there.
You're saying when to go to the emergency room or what?
In terms of cautery, COBLATION, how to think about that treatment option, when is too many times, a lot of questions
I
about.
see.
Yep.
Okay, so I mean the real answer is long. So I think I'm going to back up a second too. I'm lucky in that I have two monitors in my clinic room. So I have a monitor behind the patient that I can see when I'm looking in the nose with the scope, and then I have a monitor behind me that the patient and the family can see. And so I'm really big on what I call shared decision making. And so, we put everything together with what's their epistaxis severity score, what are their hemoglobin levels, what are their ferritin levels, how many meds are they already on to help the nosebleeds, and what does it look like in the nose? Because I want to look in and show, you do already have a perf, you don't, if you don't have a perf and you're getting, a very mild bipolar, irrigating cautery or COBLATION or sclero, I don't know that there's a wrong number or too many. That we always like to keep people out of the operating room and avoid general anesthesia just because of the cost and the downtime and the risk. So I mean, I think it's individualized for each patient, and it depends on, is there already some irreversible damage in the nose? It's kind of a wimpy way to answer that, but those are the kind of things I think about.
Sounds good. Thank you for that. This is a really interesting question I'm seeing here, and not to put you on the spot, but it's almost asking you to get out your HHT crystal ball. But curious what you see as kind of the future of epistaxis treatment in HHT, with more and more therapies being available, some just in trial phase right now. But secondarily, why having options is important for HHT patients.
Sure. So having options is huge is that some people either don't respond to some, or some people have side effects. So I have several people who doxycycline works great on, but it's an antibiotic and it can mess up your gut and give you diarrhea. And so people have had to get off of that. So I always try to stay as topical as I can, just because I know that the side effects are going to be less. Looking at different products that could either, be in the nose long term and still let patients breathe, whether that's something that's sutured in or implanted or a gel. That's one area that I think a lot of us are looking at, and then a lot of us too are waiting on the pazopanib results. Certainly, bevacizumab is a great option. I did see a question about long-term stuff, and that's a concern, right? Because it can mess with the kidneys, it can cause clots, can cause a couple other side effects. Each patient I have, I promise, is almost on a different regimen of Avastin. And so again, thankfully, we don't have to have everybody on these long-term systemic therapies, but I mean, probably my crystal ball says that for the next 5 to 10 years, if we're on maybe one systemic and one topical treatment, we can probably control most people. I think the problem with the topical stuff is like, does it have to be administered in office versus at home? Because, Gainesville is a small town. There's only 30 something centers around. And so for some patients, travel is a huge burden.
Certainly. Appreciate that answer. I've seen this question come up a lot, both in the pre-chat registration where a lot of folks got their questions in early and here live. But the question is, when would you advise going to the emergency room for a bleed?
Sure. And so I think for most people, if you're bleeding for an hour, I would go. If you're already anemic, I'd probably go after 30 minutes. I mean, the only problem I have with going to the ER is like you almost always buy yourself a pack, depending on, where you are and who the consultants could be. If the place doesn't have an ENT consultant, then you're probably going to get one of those balloons, which are painful and have to be pulled out later. If an ENT is available, hopefully they could do an absorbable pack. And, you know, hopefully I do too. Bleed cease, I have no commercial relationship with bleed cease, but I tell all my patients to have that with them at all times because I'm a believer too. If you can get it stopped by yourself in 45 minutes at home, probably are going to avoid some trauma to your nose by avoiding the ER. But certainly, in a life-threatening situation, I always would err on the side of caution.
Absolutely. Thank you for that. Question in from Julie just now in the chat live, and several others have asked it as well, but asking about, is there any long-term impact or concern with long-term TXA?
So it's a great question. We actually asked Raj that at the meeting in Seattle, and because I never prescribed oral TXA in residency, and it really only picked up doing it in the last 3 to 4 years. According to the hematologist that I work with, it is safe and can be given long term. Bear in mind that as we get older and we get at risk for AFib or any other clotting thing, that could become a risk. But I'm not aware of any, outside the clotting world, as far as like damaging kidneys, damaging liver, stuff like that. I'm unaware of any long-term side effects of TXA. Now, I'll tell you, as the irony, and this is not in an HHT patient, I had a colleague who was doing a sinus surgery on someone with a sinus problem about a year ago who called and said, they're in the recovery room and they're bleeding like crazy. What do I do? And I was like, just give them some TXA. Do they have any clotting things, AFib? No, 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 no. And so they gave this patient TXA, her bleeding stopped. And then a week later, she had a pulmonary embolus, and was like, well, what's going on? Well, it turns out she had been on a really rare autoimmune medication that caused clots, and nobody picked that up. So, I don't want to say, like, from my experience, it's 1,000% benign, but in general, outside of people who have pre-existing clots, long-term TXA is thought to be safe.
Thank you for that.
And the thing about TXA, patients will try to minimize their dose because of that. And the hematologists have stressed to me that if you're not taking it every 8 hours, then it's not doing its job.
Absolutely. Seeing a lot of questions in the chat about our pazopanib clinical trial. While we can't share any results about that trial just yet, as you've heard Dr. Justice share, it's so important to continue to push for various treatment options for patients. HHT certainly isn't a one-size-fits-all disease. So hoping the future includes many options for many different patients so we can find something that everybody responds to. Seeing a question here asking about treatment of nosebleeds in children and how that differs for management in adult patients.
Sure. So luckily the bleeds are not that bad. I actually yesterday did sclerotherapy on a 16-year-old because she actually had pretty bad bleeds. But when I looked in her nose, she said, I only bleed on the left. And so I looked in the right side, no lesions whatsoever, looked in the left, and she only had one. And she's a pretty stoic, brave little girl, and we numbed her up and she did sclero and she did great. Again, I try to avoid doxy in people like under age 14, age 16. I don't have experience giving TXA to anybody under 12. I would have them have a discussion with the hematologist before I would do that. But I would tell you, I don't think I've had to take anybody less than 12 to the operating room. I think most of children, if I can get them on, that again, children are not the most compliant patients, right? So that's why I'm saying sclero is great because you don't have to go to the operating room, or if they're a little kid, you do, but you're not causing a lot of collateral damage. You're not giving them anything systemic. But most of them I can manage with the topical gels and ointments like Vaseline, mupirocin, AYR, Aquaphor.
Absolutely. Speaking of gels and topical therapies, gotten a lot of questions if there are any products you would recommend over others.
Sure. I mean, I don't know that I can speak to brand names, but certainly the generic mupirocin is probably my go-to. Vaseline certainly works. There's these theoretical risks of getting lipoid pneumonia from Vaseline and mupirocin. I've never seen that in 20 to 25 years. I mean, certainly if you swallow a whole bottle or, if you aspirate a whole bottle, sure. But the small amounts that people are putting in their nose, I've never seen a problem with that. I have some people who love and swear by Aquaphor. I have some people who love and swear by rose geranium oil. And I'm trying to think if there's any other ones that pop up a lot. I don't think so. If I think of it, it'll come up. But those would probably be the main ones I can think of.
Sounds good. Thank you for that. We gotten a lot of questions in this vein, I suppose. But it's always a hot button topic in the Facebook groups as well. So I have to ask, but a lot of questions about food being bleeding triggers. What's your response to that?
Okay, sure. So the short answer is I don't know. I think everybody's different. I will tell you, I have two patients who swear to me that when they changed, and I don't know if the question is about the act of eating or about the type of diet, but I'm going to address both. I have two patients who swear that going vegan stopped their nosebleeds. I don't know why, and I don't know how, but they've kept at it, and they tell me that they're nosebleed free. I just tell my patients should just eat a healthy, balanced, low fat diet. So I will tell you, the act of, if you look at my face, like the act of chewing and moving your upper lip actually pulls your parts of the front of your nose down. So I have several patients who do this, like they bleed a lot when they eat. And I believe that it's because the clots that are already there are being dislodged by the act of the chewing. I can't prove that to you, but that's my hypothesis.
Absolutely. Last few for you here. Appreciate staying on for the extra time. A lot of questions asking about therapeutic treatment in addition to surgical treatment or intervention as well. Is that an option? When should that be considered type of questions?
So wait, are you saying medical therapy at the same time as surgical?
Sure. So like an Avastin in conjunction with a sclerotherapy or something like that.
Oh, sure. Yeah, that's very common. Anytime we go to the operating room, certainly it's reasonable to try Avastin. Like I said, the original study showed good efficacy. Some later studies did not. Again, I think it's probably kind of like the doxy thing, is that you're going to have some responders and non-responders. I don't think topical Avastin works well when it's just placed like inside the nostril on the surface. but I do have several patients who seem to do better when it's injected. And you can inject Avastin in pretty much any case you do in the operating room. I'm trying to think of a situation where you couldn't. I mean, if you had to, remove a turbinate or something, I guess you could, but that luckily that's rare, and I really can't think of a situation where I at least offer. I never push, injections of Avastin, but if the patients are interested or they think they've had benefit in the past, I think it's a reasonable thing to try.
Sounds good. Thank you so much. Before we wrap things up tonight, Dr. Justice wanted to ask a more open-ended question. Anything else you'd like to address before we sign off here? Any common myths or questions you get in clinic or anything more broadly you'd like to share with the community?
Sure, sure. I saw a question of asking about humidity.
Sure.
That's interesting, because I live in Florida and it's super duper humid. We have not done any studies on that. Being in Utah, I actually thought it was worse. The run of the mill, the non-HHT run of the mill nosebleeds were way worse in Utah than in Florida, and we think it's because of the cool, dry air. But I hear mixed things from patients. I will hear people in Florida say that they do better in the winter, and not that it's cold, but it's cooler and drier, and they'll bleed more in the hot, humid summer, which is the opposite of my experience in residency. So I actually don't know. I guess my theory on that is if you formed clots, then maybe the humidity is helping them fall off, but also so should air movement that's drying you out. So I think the humidity is something that we might never know.
Sounds good. We have one more interesting question if you'll bear with me here, but any, whether it's anecdotal or research driven response from patients in treatment variation based on mutation, whether you're an endoglin or an ALK patient?
Yeah. So I think we're going to eventually find that. I haven't found it yet. I'm looking at that with Doxy and a couple other things right now. But that's, I mean, yeah, it seems to me like the pathophys should be a little bit different. But I haven't seen it yet, but I suspect that we will.
Absolutely.
And I,
And the hope is to certainly push for more targeted therapies.
yeah, exactly, exactly. I
Yeah.
saw another one about sneezing. Yeah, I tell every one of my sinus and HHT patients cough and sneeze with mouth open. Try not to blow your nose unless you really have to, and sneeze with your mouth open for sure.
Absolutely. Dr. Justice, we so appreciate the time here tonight, but more importantly, all the care and support you've given to the HHT community at your center. We appreciate everybody joining us here tonight. If we didn't get to your questions, pick up the phone, give us a call, send us an email. At the end of the day, we are here for you. We are your organization and here to help. As I said at the top of the call, you will also be receiving a survey. Please do take a few minutes to fill that out and let us know topics you'd be interested in hearing more for. We want to ensure our resources are patient focused and doing the best to support you throughout your journey with HHT. With that, we'll sign off for the night. We hope everybody enjoyed tonight's program, and thanks again to Dr. Justice for his time and support. Bye, everybody.